You have a particularly interesting case of CDK46 inhibitor use potentially in early stage hormone receptor positive breast cancer. I was wondering if you could present the case to us and take us through a bit of a discussion.
So this is 39 years old premenopausal women presented with palpable right breast lump. In MRI, a diffuse mass of around 5 centimeters was seen in upper interquadrant of the right breast, plus enlarged axillary lymph nodes in the same site. A core biopsy with sonographic control was performed, showing invasive ductal carcinoma grade 3, ER positive, PR positive, HER2 negative, Ki67 high, 45%. So a fine needle aspiration of one of the axillary lymph nodes was also performed, showing metastasis of carcinoma. We did a PET scan, and the PET scan only showed the lump in the breast and the axillary lymph nodes. No metastases were apparent in any part. So the clinical diagnosis was CT2, CN1M0, luminal breast cancer in a premenopausal women.
So this is a really high-risk case. It's very, I imagine, very upsetting for this woman to have such a high-grade breast cancer, such a high Ki67, already with axillary lymph nodes involved, and a woman who's younger than the age of 40. So can you tell us how you think about management in the curative setting like this, but a very high-risk early-stage breast cancer?
I think that in that situation, we have two goals. One is to achieve appropriate local regional control, and this is done by surgery and radiation, and probably more important, distant control as well through systemic therapy, including chemotherapy, endocrine therapy, bisphosphonates for postmenopausal women, and recently Cdk46 inhibitors. And we can administer these therapies in two different sequences. We can start with local therapy and then move to systemic treatment, or we can as well start with chemotherapy, systemic therapy, move then to surgery and radiation, and after that continue with the remaining adjuvant therapy, endocrine therapy, bisphosphonates in postmenopausal women, CDK4 inhibitors. Well, the different systemic therapies are could be given before or after surgery, particularly chemo or endocrine therapy. Regarding chemo, we know that the administration of chemotherapy before or after surgery is associated with the same outcome. The only difference is that in the old trials, in that meta-analysis, showed that neoadjuvant chemotherapy was associated with a higher risk of local relapse because there was more breast preservation surgery with neoadjuvant chemotherapy. Well, neoadjuvant chemotherapy is interesting for two things. First, it produces tumor shrinkage with downstaging in most patients, more than 70%. And this could lead to mastectomy in non-operable locally advanced patients, or to breast preservation surgery in patients with tumor of borderline size, as it is the case of our patient. And maybe we could achieve easier axillary surgery, particularly when we have enlarged axillary lymph nodes. But still more important, it could provide prognostic information The residual tumor after neoadjuvant chemotherapy is associated with survival. So we select for that particular patient the sequence neoadjuvant chemo, surgery, radiation, and then the remaining adjuvant therapies. The patients received neoadjuvant artemisinin cyclophosphamide, AC, 4 cycles, followed by weekly paclitaxel. She kept regular menses in spite of the therapy, but she had a very good response clinically and by imaging. Lumpectomy plus axillary node dissection were performed, and the pathological response of the lumpectomy specimen and axillary specimen showed residual breast cancer invasive of 1 centimeter, 90% cellularity, 3 axillary lymph nodes involved out of 11 removed, the largest one 15 millimeters large. The tumor still was ER 80%, PGR 35%, HER2 negative, K67 25%. So looking at the RCB classification by Siemens et al., a classification that provides a good estimate of prognosis, it is a RCB3, so the worst case scenario, unfortunately, expected due to the high tumor burden of the patient at diagnosis.
Wow, Miguel, that must have been very disappointing. You gave her state-of-the-art chemotherapy, and it looked like she was having a great response, but there was a lot of residual disease. We know residual disease at the time of surgery after neoadjuvant therapy for triple-negative and HER2-positive breast cancer predicts a particularly poor prognosis. What do we know about the presence of residual disease in hormone receptor-positive HER2-negative cancer like this? Do we have any data?
You can see here the group of patients with hormone receptor-positive, HER2-negative, treated in the neoadjuvant setting with taxanes and anthracyclines, and then with endocrine therapy. And you can see here that the residual cancer burden is prognostic of outcome. Patients with stage 0 PCR or 1 have a very good prognosis. Patients with RCB3 have more than 50% relapse rate in the long term, while patients with RCB2 are in the middle.
So your patients got a shockingly poor 5-year and 10-year event-free survival based on these data. Talk to me about how you consider systemic therapy in the adjuvant setting based on these data, because presumably these patients that were included in the Siemens study did have access to endocrine therapy, modern endocrine therapy. Can we do better than these numbers would project?
Yes, I think so, because this series is relatively old. So I guess that the only endocrine therapy for premenopausal women in particular is tamoxifen, that series. And maybe we can do better after the TEACH and SOFT trials, data showing that the addition of ovarian suppression to either tamoxifen or exemestane could improve the results of the high-risk population of premenopausal women. In addition to that, we have the new compounds, the Cdk46 inhibitors. Do not forget that radiation is also important for that patients, particularly with axillary involvement. We have a large meta-analysis showing that radiation reduces not only local recurrence, but also distant recurrence and reduce overall mortality in patients with axillary involvement. So I think this is an important part. And our patients receive radiation to the breast and axillary local renal lymph nodes. And after that, as you mentioned, Sarah, what to do regarding endocrine adjuvant therapy? I think that two academic trials, the text trial and the soft trial, tested the interest of adding ovarian suppression to the standard endocrine therapy, including aromatase inhibitors for premenopausal women. New thing, you can do that if you produce ovarian ablation to the patient. And here you have the results. I think they are practice changing. When you add ovarian suppression, usually ocellarin, to either tamoxifen or exemestane, patients had a reduction in relapse rate, but only when they had received chemotherapy previously. But in that case, chemotherapy is a surrogate of higher risk rather than the key issue itself. So we should conclude after the text and soft studies that patients in premenopausal status after chemotherapy at high risk should receive the combination of ovarian suppression and probably exemestane, because exemestane perform a little better than tamoxifen in combination with ovarian suppression.
So your patient is going to get radiation, ovarian suppression, exemestane, which hopefully she'll tolerate well because this is tough. And because she'll be on ovarian suppression, she'd be a candidate for a bisphosphonate therapy, presumably as well. What about the use of a CDK46 inhibitor? Is that something that's supported by the data? And if it is there one that appears to be better than the other? Can you go through the data and let us know how you're integrating CDK46 inhibitors in your practice if you are in the early stage setting?
3 studies have been published, the results disclosed, the PALAS, Penelope V, and the Monarch E. A trial is awaiting results. The Natalie with ribociclib has ended enrollment, is pending a follow-up, and there are 2 trials still recruiting, the ADAPT cycle and the ADAPT late. I would like to show you the results of the Penelope B study with a very modern design, risk-adjusted design, in which luminal breast cancer patients, operable breast cancer patients, received neoadjuvant chemotherapy, and those having significant residual disease, in that case, classified according to the CPS-EG score, were randomized after surgery to receive the standard endocrine therapy plus placebo or plus 1 year of palbociclib. And here you have the key efficacy results, no differences in invasive disease-free survival and in overall survival. In the subgroup analysis performed in patients in which tumors were available for determining the intrinsic subtype, you can see that a small proportion of patients having luminal P subtype after neoadjuvant chemotherapy seems to have a benefit with palbociclib versus placebo. But of course, this is exploratory analysis, and the number of patients were quite small. Patients having luminal A subtype after neoadjuvant chemotherapy didn't achieve any benefit by adding palbociclib to endocrine therapy. Of course, this is hypothesis generating, and we should have more information in the future. Well, the second study with palbo is the PALAS study. This is a post-surgery study, adjuvant study, randomizing patients at high risk, moderate to high risk, axillary positively nodes to endocrine therapy alone or endocrine therapy plus palbociclib for 2 years, and no difference at all in the main endpoints, invasive disease-free survival or distant relapse-free survival. So palbociclib in the adjuvant setting didn't work in the PALACE trial.
So we have two large negative studies with palbociclib in the adjuvant setting, one in particularly high-risk patients with very long follow-up. The dropout rate on PALACE was around 40%. With Penelope B, it was lower. And so we don't really have any evidence that it's benefiting patients. What about abemaciclib? What does that data show?
The Monarch E is very similar to the PALACE design, although higher risk patients were enrolled. Patients had 4+ axillary lymph nodes or 1 to 3 and an additional high risk feature, usually K67 over 20%. So patients were randomized to 2 years of abemaciclib plus endocrine therapy or endocrine therapy alone. And the updated results published very recently after a median follow-up of 27 months show that there is a benefit in favor of abemaciclib in invasive disease-free survival and distant relapse-free survival as well, with a hazard ratio of 0.68, a very good hazard ratio considering we are in the adjuvant setting. So these are very interesting and encouraging results, and the FDA, based on that results, has approved abemaciclib for the adjuvant treatment of high-risk luminal patients with high K67. Well, the other side of the coin is the safety of the drug, but I think that if we are able to control diarrhea properly with abemaciclib, we could keep the patients on therapy along the 2 years of treatment. We should provide patients with loperamide and inform them that this could happen, and they should have loperamide available to start in case of diarrhea, and that way diarrhea is usually well controlled. On the other hand, diarrhea is most important in the first 1 to 2 months, and then decline very, very significantly. In fact, most patients in the Monarch E study would end the 2-year trial, and this is different from what happened with palbociclib in the adjuvant palbociclib trials.
So let me ask you a quick question, Miguel. You know, this low rate of venous thromboembolic events, which is significantly higher than you see in the placebo arm. Are you avoiding the use of tamoxifen and combining it with abemaciclib due to venous thromboembolic events, or are you screening your patients in any particular way? How do you approach that?
I agree with you. We should avoid tamoxifen if possible, because tamoxifen itself increases the risk of thrombosis. So the combination of abemaciclib and tamoxifen is probably the worst among the possible combination. We could combine abemaciclib with aromatase inhibitors. Think that even in the case of premenopausal women, if we consider them high risk, the standard therapy today should be ovarian suppression plus, why not, an aromatase inhibitor. So we could avoid tamoxifen in the majority of the patients.
Wonderful. So tell us, how did you end up treating this young woman?
Well, unfortunately, abemaciclib was not available when the patient was operated. The Monarch E trial was ongoing at that time, and she started ovarian suppression plus exemestane. We make sure that the estradiol levels go very low in the postmenopausal range. This is very important when you use ovarian suppression in young women, because some of them could have still high estradiol levels. In that particular patient, estradiol levels were in the postmenopausal range, and she's ongoing with ocelerine plus exemestane and doing very well. Abemaciclib is available in the US. How are you feeling regarding the use of this drug?
I'm very pleased that we now have this available, and pleased that the 27-month follow-up shows a consistent benefit over time. I think many of us were worried that the Kaplan-Meier curves would come together with time. So I'm looking forward to seeing further follow-up data, but the data does suggest a benefit. And so I am very happy we have it available. There are some challenges, however. Ki-67 testing, as you know, there is a lot of interlaboratory variability, lack of standardization, especially in labs that don't perform this assay often. And so the requirement that the Ki-67 be 20% or greater is going to force institutions to run Ki-67. And I worry that the lab values may vary. If somebody comes back with the Ki-67 of 15% in one lab, it may be 25% in a different lab. So it's going to be interesting to see how that sorts itself out. I'm also interested not only in the longer term follow-up data, but what are we going to do if a patient has disease recur after having abemaciclib in the adjuvant setting? That's going to raise a number of questions about how to ideally treat them in the first-line metastatic setting. So always, everything that happens in oncology begs new questions. It's a very interesting time, but I'm excited to have this available for my highest risk patients now.
Okay, I think that if you agree, Sarah, we could move to the metastatic setting, because I think you have a very interesting patient to present.
So I have a 67-year-old woman who has a history of a stage 2A ER/PR positive HER2 negative left breast cancer 8 years ago. She had breast conserving surgery and radiation, as well as 5 years of anastrozole. 2 years after completing anastrozole, she was found to have a mildly elevated liver transaminase on routine blood work through her primary care provider. She underwent imaging that did reveal liver metastases up to 2 centimeters in size, as well as one left upper lobe lung mass and diffuse bony metastases. It is remarkable that she was not symptomatic with the burden of disease that we did find. A biopsy of the liver revealed ER positive, PR negative, HER2 negative metastatic breast cancer. Her ECOG performance status is good, it's a 1, and she has only mild right upper quadrant pain after undergoing her liver biopsy. So I have a lot of thoughts about this particular patient because she has such a heavy disease burden, and I know that some people would think of reflexively giving a patient chemotherapy in this situation versus a CDK4/6 inhibitor. There's a lot of other questions, I think, that come up as it relates to choosing a best first-line therapy in this particular patient. I don't think this patient, given her lack of much in the way of symptoms, her liver transaminase was only grade 2 elevation, so I didn't see this as a situation mandating hospitalization and initiation of chemotherapy. But a lot of other questions come up in terms of which CDK4/6 inhibitor to use, if we're going to be using one, and which endocrine partner to use in this case. She had anastrozole in the adjuvant setting, but it's been 2 years since she received an AI. and whether or not age matters in the selection of therapy. Before I go on through some of the data, I would like to know your thoughts on how you choose an endocrine partner, assuming you're going to use a CDK4/6 inhibitor in the first-line setting.
Well, this is an excellent question, and a recent trial, the Parsifal trial, has addressed this issue. I think that only in patients with a very early relapse during aromatase inhibitors, you should use fulvestrant together with the CDK4/6 inhibitors, because probably in the remaining patients, fulvestrant and aromatase inhibitors in combination with CDK4/6 inhibitors works very similarly. And if you start with aromatase inhibitors plus CDK4/6 inhibitor, you still have fulvestrant for second line. This could be very relevant in practical terms in some countries, in Europe particularly, because if you are going to use in second line, for instance, alpelisib, you must combine alpelisib with fulvestrant. So keeping fulvestrant for the second line could be a good idea. Probably both are good options, but I personally prefer to keep on aromatase inhibitor, maybe changing the one when adding CDK4/6, particularly if the patient has been on aromatase inhibitor for more than 2 years.
Yeah, those are good points. I think we have to, as clinicians, always be looking ahead to what we do at the time of progression, and your points are very salient. Just to review, the CDK4/6 inhibitors we have available now include palbociclib, abemaciclib, and ribociclib, and they're not simply different flavors of the same drug. In my opinion, they have different chemical structures, and if you consider all of the phase 3 clinical trials that have been done that have looked at these agents when added to endocrine therapy, they do all have a strikingly similar hazard ratio, somewhere around 0.5, in terms of improving progression-free survival, all of them meeting statistical significance for progression-free survival. But where we're beginning to potentially see differences among the agents is when we start to see overall survival data mature and be reported out. And for now, ribociclib and abemaciclib are the two agents associated with a statistically significant improvement in overall survival, whereas palbociclib has only reported out PALOMA-3 thus far, and statistical significance for overall survival benefit was not met. Now, it could be that the patient population or study design was different or powering such that survival wasn't able to be shown, but it is an interesting finding. Now, the MONALEESA-2 study was recently presented at ESMO. This is the very first study to show survival benefit with a CDK4/6 inhibitor combined with an aromatase inhibitor in postmenopausal women in the frontline setting. In this study, patients were randomly assigned 1-to-1 to ribociclib plus an AI or placebo plus an AI. It was a frontline setting study powered for progression-free survival with an overall survival endpoint as secondary, and a key secondary endpoint. And in this study, the use of ribociclib was associated with more than a 12-month, about a year improvement in overall survival. The median overall survival was almost 64 months, which I think is historic. Can you recall a study in hormone receptor positive, HER2 negative metastatic disease with a median overall survival of that long, Miguel?
Well, I think that in the past, the best results we had with aromatase inhibitors in first line is of around 4 years of overall survival in median. So we have improved 1 year, at least, maybe a little more with this new class of drugs, at least with ribociclib. We don't know if this is a class effect yet. We will know this very soon, in a few months. But I think this is remarkable because improving survival in metastatic breast cancer is a challenge. Very few drugs has improved survival so far in metastatic breast cancer. So I think this is a very, very relevant information. In fact, I think this is a revolution in the therapy of metastatic breast cancer. And I'm curious to see what happened with abemaciclib and palbociclib in first line as well.
Yes, yes, indeed. Me too. And I think it's also interesting that they demonstrated an improved time to first chemotherapy, which is important. There were no subgroups who didn't appear to benefit from a survival standpoint in their forest plot analysis. And interestingly, the delta, the difference between the treatment arms in terms of overall survival, widened or increased over time, such that at 4 years, there was a difference of about 6% between the two treatment arms in terms of overall survival. But by 6 years, it was about 12%, indicating that that benefit is durable and prolonged. We have seen data suggesting a strong trend toward improvement in overall survival with palbociclib in the second-line setting when combined with fulvestrant. There was an analysis that was presented at ASCO in 2021 by Professor Christoph Finelli looking at the Paloma-3 data based on ESR mutation status. And he showed that the ESR mutated cancers do worse overall, but palbociclib still benefits these patients. You presented data relating to PEARL, long-term survival data, at ESMO, but there was this very interesting poster presented at ASCO looking at CDK4 inhibitor resistance and the use of a CDK4 inhibitor versus capecitabine based on high cyclin E expression levels. And it was very interesting that those patients with tumor cyclin E overexpression or high expression levels seem to benefit more from capecitabine. Is that something you're using in practice to determine whether or not a patient receives a CDK4 inhibitor?
Well, not yet, because this is hypothesis generating. I think that Nick Turner has found the same in the Paloma-3 trial, but to be honest, I think we need more data before accepting that as a biomarker of palbociclib. But if this is confirmed, this will be very good because so far, as you know very well, we don't have any biomarker of efficacy of palbociclib apart from the ER status. So let's hope that other studies confirm these findings.
I agree. The design of your PEARL trial didn't show that palbociclib was better than capecitabine in terms of PFS or OS. It already also didn't show that capecitabine was significantly better than palbociclib, so sort of underscoring that the outcomes look fairly similar for the two groups. But I agree, we need biomarkers to help us select out patients who may be having de novo resistance to these agents. Right now, we don't have that in the clinical setting. And I do think that it's important, the patient I presented was 67 years old. And so some would wonder whether or not we should be differing our treatment recommendations for patients who are older than 65, older than 75. And actually, there was some real-world data presented by Hope Rugo at ESMO indicating that patients who are older than 65 and even older than 75 do appear to benefit from palbociclib, both in terms of progression-free survival and overall survival. Clinical benefit rates also look very good for women who are 75 years or older based on some data from the UK looking at PFS and OS as well as objective response rate and clinical benefit rate. So I think as long as your patient doesn't have a poor performance status, the use of a CDK4 inhibitor, even in older women, is supported by the evidence. Would you agree?
I fully agree with you. I think that age itself should not be a criteria for exclusion. The only comment I would add is that older women usually have many medications because they have hypertension, diabetes, and when using some of the CDK46 inhibitors, we should be very careful with drug-to-drug interactions. But that's all. I think you could use CDK46 inhibitors in older women.
I agree. So I think this patient did end up going on an aromatase inhibitor plus ribociclib, and she continues to do very well. So thank you so much for being here with me today. Miguel, do you have any last comments regarding the use of CDK4/6 inhibitors for ER-positive breast cancer that you'd like to share?
Well, I think that we all agree that this is a major advance in the therapy of the disease. I think that there is a trend towards using them in first line, in the metastatic setting, because you should use the best drugs first, and the impact on overall survival probably will be more if you use the drugs in first line. I don't know if you agree with me.
I completely agree with you. I think now that we're seeing survival benefits from Mona Lisa 7 and now Mona Lisa 2 in the frontline setting, I think this should be the standard of care where available. I'm excited to see the data from Monarch 3 and Paloma 2. I'm hoping that these agents also support survival benefits. And I'm really excited that we have abemaciclib available for patients with high risk ER-positive breast cancer in the curative setting, but looking forward to seeing the Natalie data and hoping that we have another agent that also shows benefit there. Thank you so much for being with us today. I hope you've enjoyed this activity.